Hello, everybody. Welcome to this first webinar of Dental Implants, the Course One-on-One Training in preparation to your trip to Guadalajara, Mexico, where you're going to be doing this live patient training over the next 4 days in the near future.
My name is Emilio Arguello, and right next to me, Dr. Marcus Schamer. We are the co-directors of this course. Along with us, we have a lot of faculty. All our faculty will be specialists in the field. We have from periodontists to oral maxillofacial surgeons that will be side by side training you right on site in Guadalajara.
When you arrive to Guadalajara, there's a few important things that we want you to keep in mind. You're going to be responsible for your arrangement of your flights. And for that purpose, you're going to have to fill and submit this form that has your arrival flights and your departure flights. So then we can coordinate a private transportation that will take you from the airport to the hotel, and at the end of the course from the hotel to the airport. In this case, we're going to be staying at the Hyatt Regency Guadalajara, located in the prestigious Andares Shopping Center. And for those of you that like to work out in the mornings or at night after the course, please make sure that you bring some shorts and tennis shoes so you can jump into this state-of-the-art gym and this beautiful indoor pool. Also, as part of your reservation, breakfast is included from 6:30 a.m. until 8:30 a.m. because at 8:30 a.m. we're going to be transporting you on days Thursday, Friday, Saturday, and Sunday to the surgical center where all the clinical practices are going to take place at. So make sure that at 8:30 a.m. you finish your breakfast and you're ready to join the crew with this private transportation that will take you to the clinic.
Our week will be divided in 4 days, and the first day will be Thursday, where we start with breakfast between 6:30 and 8:30, as Dr. Mark Shaman mentioned. We'll then transfer from the 8:30 to 9 o'clock. So our first session starts in hands-on training, where you will be able to experience some suturing protocols, some drilling protocols, and the use of a piezoelectric machine, which is supported by Action, one of our partners for this course. And you will be able to practice some sinus leaf access in models, and you will be able to be ready to perform your first surgery at 11 o'clock a.m. And that surgical session goes until 2 p.m. Then we will be breaking in groups as we're finishing our first patients for lunch between 2 to 3 p.m. And then our second session for surgery will be from 3 to 6 p.m. Then we'll be back to the hotel between 6 to 6:30, and that evening you have that at your leisure to be able to enjoy some of the things that local center has to offer.
On Friday, the day's a little bit different. We're not going to have any hands-on. We're going to have breakfast at the same time, 6:30 to 8:30, transfer from 8:30 to 9, and then we're going to have a short lecture reviewing some protocols from 9 to 9:30. So straight at 9:30 to 11:30, we can jump to our third session of surgery. Our fourth session of surgery is going to take place from 11:30 a.m. to 1:30 p.m. with our break for lunch between 1:30 and 2:30 p.m. So we can jump into our last surgery of the day from 2:30 p.m. all the way to 6:30 p.m. and then transfer back to the hotel, where in that plaza you're going to have many places to go out for dinner, enjoy shopping, and have a lot of fun as well.
Then the following day is similar to Friday, and Sunday we'll finish our course at the closing ceremony between 1 and 2 p.m., where we'll have only 1 or 2 sessions in the morning, according to how many, if you're not too tired. However, in the evening, we'll have the afternoon and the evening free. We're going to visit Tlaquepaque, which is a local attraction. There is a lot of handmade goods, and obviously the city of Mariachi will also be visiting the store that has the Guinness record for the most tequilas in the world. So from there on, we're going to enjoy some dinner together. We're going to the local culture, and we will prepare to the private transportation to the city of departure back home.
You're going to be getting a bucket list or wish list. Please make sure that you really put yourself into which type of category of training do you have in implant dentistry. You can either be a novice, an intermediate, or an advanced. And out of that group, choose the amount of procedures that you would like to do, or so we can maximize your experience and we can choose the right patients for you for this course. So for example, on the novice, we have several categories. You're going to select 5 of the 8 if you're a novice surgeon. If you're an intermediate surgeon, please select 6 out of the 10 surgical procedures so we can start selecting the type of procedures that you're going to be doing during that time. And if you're in the advanced, please make sure that you select 5 of the 8 surgical procedures, and that way we'll also make sure that for those advanced practitioners we can select the right cases.
This is very important because ultimately our faculty members will be helping you side by side, and our faculty members want to make sure that you have the correct experience and they maximize the capacities that you want to train. So if you are a beginner and you select procedures from the advanced category, it doesn't mean that you cannot perform those. It just means that you have to have a certain level of a skill that you have already pre-trained in order to do those cases. However, at the beginner level, many times we help you out and to select a bonus category right on site, depending if you want to just learn something else. So as we mentioned, we have only faculty that are oral and maxillofacial surgeons right on site. They're very well-known clinicians right in Mexico, and many of them have been trained in the States as well. In addition, part of our faculty, we have board-certified periodontists, all trained in the United States, and most of us with academic appointments in different institutions through the United States.
A little bit of reading to get prepared for the course. These are 2 short readings that we recommend that you read before you go to the course. It's going to give you an overview of implant dentistry. For those of you that already have some implant dentistry training, it also helps you to refresh your mind on some of the concepts. So I would encourage everybody to go to those 2 links and review those 2 papers. They're easy readings and it will help everybody to be on the same page. Now, for those of you that want a little bit more in-depth experience, these are 4 of the books that we would recommend people to buy or to get. If you want a little bit more detail and to want to get a little bit more into the biology, into the mechanics, into the prosthetics, a little bit more in detail. Okay, with this, we're going to start the core of the lecture. And how can we start without treatment planning?
In treatment planning, we have different aspects that we have to look into. We have biological considerations, preoperative general assessments, prosthetic considerations, and surgical considerations. But you see all of them overlap to one another to make sure that we have a successful treatment. Let's look into biologic considerations. We start first that in Toronto, 1982, Professor Brandenmark showed the study of osseointegrated implants in the treatment of the dentulous jaw. This led to an understanding of the concept of osseointegration, which is defined as a direct connection between living bone and a load-carrying endosseous implant at the light microscopic level. But then that is biologically, but we also have a clinical osseointegration, which is an asymptomatic rigid fixation of an alloplastic material, in this case the implant, in bone with the ability to withstand occlusal forces, which means we know that there is not a true fusion between this implant and the bone. We have an integration, an intimate contact. But with the loading forces and a clinical osseointegration, we're going to make sure that this screw doesn't move, and that's where the concept of clinical osseointegration happens. Now, we have to understand 2 concepts. When we look at the bone healing around implants, we have 2 different concepts. The one on the left side shows distance osteogenesis. That happens when an implant surface is placed into the preparation of the osteotomy, But this implant surface doesn't have a characteristics that will be able to attract all the osteogenic cells to grow right next to the implant. What that means for you is that an example of this will be a machine implant that is not a roughened surface, where in the left side we see the matrix of bone forming by the osteogenic cells away from this surface. And eventually, this distant osteogenesis, that matrix is gonna come together and hold the implant surface. The one on the right side has a contact osteogenesis, and that means that the implant has elements included in the surface that will help to develop that matrix of bone around in contact with the implant and away from the implant to fill in the osteotomy that you have created. What that means is that nowadays, most of our implants that we use are exactly that, are roughened surface implants. So what you see in the slide on the left side is when we have a contact osteogenesis, right? There is an attraction mechanism of these progenitor cells to sit on top of the implant surface and create that matrix of bone. The one on the right, as you see, the distant osteogenesis, actually there's a conglomerate of cells that come together and one against the other, away from the implant surface, create a new bone matrix. And that is the example of contact and distant osteogenesis. Obviously, the contact one has an effective fibrin retention. The other one has an inadequate fibrin retention. For that, we can tell that we have many implants in the market, but not all the implants are made the same. That means that we have to also understand the alveolar ridge.
So let's start talking about the alveolar ridge, because that's where we're going to be putting our implants. And we need to understand what happens with this alveolar ridge as we lose the teeth, and what happens with that alveolar ridge with time. So back in the day, Lacholm and Zarb created this classification, or a very similar classification, where they saw that as people lose their teeth and as they age, they start to lose bone. Okay, and we can see that on a type A ridge, it's very simple and easy to place an implant because we're going to have a lot of bone. But as we start moving down towards F, we're going to have a much worse case scenario where we may not be able to place implants, or we will need to do other procedures in preparation to be able to place those implants. So those are things that you need to start thinking about. Well, I'm a novice type of surgeon. I want to focus more on simple cases, straightforward cases, or if you're more intermediate, you may want to do some cases where we're doing some grafting at the same time, or if you're more advanced, then you want to rebuild the bone, or you want to do cases on more complicated scenarios. Another classification that Brannemacher and Zarb came with was the bone type classification. Basically, on a type 1 bone, it's a very dense type of bone where you have a very thick cortical plate of bone and very little marrow, while on the class 2 bone type, we have a little bit more bone marrow, a thinner cortical bone compared to the type 1. And then when we go to type 3 and 4, well, the cortical starts getting less, the bone marrow starts getting bigger, and when you go to the type 4, well, we have even bigger marrow spaces. And if you start thinking about implant stability, and if you start thinking about how we're going to retain an implant, then you start thinking, well, I need to start modifying my drilling protocols. I need to start thinking, am I going to do the same thing and the same protocols for type 1 versus a type 4 bone? And a lot of that comes with experience, but if you have the right equipment, you can start getting a lot of this information ahead of time. And that's why we have a cone beam at our facility where you can start seeing all those cases ahead of time and start to give you an idea of what are you going to be facing. Do I have the volume of bone that I'm looking at for? And do I have the quality of bone? And if you don't have the quality of bone that you're looking for, well, you may need to start modifying your surgical protocols. And we're going to be helping you side by side with that.
One concept that we have to keep in mind is the concept of biologic width. Biologic width is a concept that it transpolates from what we understand of the fiber attachment around teeth shown on the left side of the slide. Around teeth, we have a sulcus epithelium, followed by a junctional epithelium, followed by tissue fibers that insert into the root and bone. What is the purpose of this biologic width? The main purpose of this biologic width is to protect the crest of the bone, which means that if this biologic width does not exist around teeth, the bone will be exposed to the surface and therefore it will go through necrosis. In implants, this biologic width does exist. We still have a junctional epithelium. We still have tissue fibers that only insert into the bone. And the magic number that we understand as a biologic width, we know that it will be a number of 3 millimeters. Now, we still have the depth of the sulcus similar that we have in the tooth. However, the sulcus will be longer because we don't have a stop on the fibers, as the fibers run parallel to the long axis of the tooth. So the bone levels are typically located approximately between 1.5 to 2 millimeters below the implant platform, typically at 1 year following the implant restoration. What does that mean for us? That this fiber attachment does develop, that does form above the crest of the bone, and the purpose is exactly that, to be able to protect the crest of the bone from the external exposure. So that means that those 3 millimeters exist, and 1 millimeter will belong to the sulcus, 1 millimeter for the epithelial attachment, which still happens around the collar of the implant, and 1 millimeter for the supracrestal connective tissue that inserts into the bone.
From here, we're going to go to the next category, which is the preoperative and general assessment. So the first thing is going to get the chief complaint of the patient. And we want a statement in the patient's own words that tells us how does the patient perceive their problem, what are their concerns, and also what are they expecting from us, or what are they expecting from their implant training or from their implant treatment. That is going to be very important, so we can then tell in a realistic way to the patients if their expectations are realistic, see how we're going to be able to help them, and they can understand better what the outcome of the treatment is going to be. The second part is going to be the medical history and the risk assessment, where we always recommend that you do a medical history where you review all of the systems. You review if there's any medical conditions you might want to add there, some specific medical conditions that might be important for you. For example, if the patient has osteoporosis and they might be taking some medications for it, if the patient is a diabetic, if the patient is a smoker, if they're taking any blood thinners, you might want to add additional things on that category. Then we're going to review and see if the patient had any surgical procedures that might interfere with our treatment. For example, replacements of hips or knees. If the patient had gastric bypass, may make us modify the type of painkillers we need to give the patients. If the patients have some certain heart conditions, so on and so forth. We're also going to review the medications that the patients take or have taken in the past, for example, bisphosphonates, or if they're currently taking any blood thinners like aspirin, Plavix, Coumadin, or other new medications like Xarelto or Eliquis.
An important aspect in this particular topic is what is the treatment that you need to do for the patient, and what are these medications and how these medications affect this treatment. It's important for you to understand that the patient has taken some form of alendronate or bisphosphonates, which such as Fosamax, Humira, or Aridia. Those are inhibitors of bone formation. So certainly they inhibit the turnover rate of bone, and therefore you don't have bone loss, but you don't have new bone formation. It's understandable within the profession that you should look into the levels of collagen telopeptide 1 that exist in the blood, for which there is a blood test that indicate the risk that is the most commonly used in our profession. That risk assessment of CTX test means that if the patient falls into the 250 and below ratio, then the patient will be more subject to have osteonecrosis of the jaw. Typically, these medications remain in your body for many years, and typically we recommend patients to stop the medication with the consent of their doctor if it's possible, and then reassess between 3 to 6 months to look at the amount of collagen turnover. The other two medications that you have to be worried about is obviously aspirin. Aspirin is a blood thinner that affects the platelet coaggregation, which means that if possible, we recommend patients to stop the aspirin regimen 7 days prior to the procedure. That way you don't have a bleeding problem during your surgery. Other medications such as warfarin, Coumadin, Xarelto, Eliquis, and others, they have blood thinning capacity, but this blood thinning capacity typically affects the vitamin K dependent factors, so it's not an immediate bleeding, it's a delayed bleeding, which means that actually the patient may be okay during the surgery, but they go home and they have a bleeding emergency. So for this type of medications, typically with the consent of the doctor, you should try to stop them at least 3 to 4 days prior to the surgery, and restart the night of or the day after the surgery, so that way they are well controlled. And just follow the MD instructions in order to continue on to the approval of the health history.
Another medication or another treatment protocol that you need to be careful with is patients that are immunosuppressed for diverse reasons, transplants or cancer. And also if the patients have history of radiation on the head or neck, that's something that you need to be careful with, because that might also have a negative impact on the capacity of the bone to heal after any type of trauma, including surgical trauma like implant placement. Review of allergies. We want to make sure that we know if the patients have any type of allergic reaction to any type of material, any type of medication, so we can select the type of materials and medications that we can use for our patients. And we want to know and review the habits that the patients have or have had in the past, because that way we can educate and guide our patients into how can they avoid those habits, how they can stop doing those habits, the impact that those habits have on their current status and on the future for those implants. Because we know, for example, that implants have a higher risk of failure on smokers, on diabetics, patients with current periodontal disease. But a lot of people are vaping nowadays, and they don't disclose that on their medical history, or they use certain drugs like marijuana or others that they may not disclose. So we need to be asking our patients a lot of questions. Even some of the medications, they've been taking them for such a long time that they forget to let us know about it. They don't even mention sometimes that they're taking a high blood pressure medication or a thyroid medication, because it's such in their routine that they don't even think about it when we're asking about it. So please make sure that when you're doing your medical history, you ask all these questions to your patients. And if you find that there's any risk on any of those categories, request for a medical release from their treating physician.
Now, just to summarize, the important conditions and systems that you have to be aware of, other than the medications that we described and the habits that Dr. Macshame just mentioned, is if you have a diabetic patient, you want to make sure that the hemoglobin A1C is below 7 to be able to be treatable. Anything above 7, that means that the diabetes is not controlled, so therefore the patient will have some type of potential for infection. Other aspects that you have to think about is the pre-medication aspect. If the patient has a recent history of a valve replacement, stent, or any type of hip or knee or other joint replacement, they may need some type of medication and follow the normal guidelines.
And of course, the dental history is going to be very important. A lot of us, we just see an x-ray and we know what's happening. We know that the patient has not taken care of. Look for caries a lot of those caries lesions, you want to make sure that you take those caries lesions away before you start treating the patients, because those abscesses could affect the healing of the implants. Of course, periodontal disease is known to be a very high risk factor for implant failure. Poor oral hygiene, and of course the occlusion. We want to make sure that the occlusion is under control before we start doing any of these treatments, or we do these treatments to help us get the occlusion under control. So any risk from any type of dental history is important. Here's a very important picture on the periodontal disease side, where you can see that the first molar has some periodontal disease, and obviously as a consequence, that implant is going to have some peri-implant disease around it. Just remember that it's the same periodontal pathogenic bacteria that are going to affect the tissues around the teeth, which are the same bacteria that are going to affect the tissues around the implants.
So that means that not because you have an implant therapy that you're going to perform on your patient that lost the teeth because of periodontal disease, that doesn't mean that the patient will be okay or immune to have periodontal disease around the implants. Actually, the patient will have the same risk of getting periimplantitis as the same risk that they have to get periodontitis.
Now let's talk about the intraoral examination and records. Of course, the first thing is we're going to look for any type of oral pathology. It doesn't have to be cancer, but any type of oral pathology, we need to be reporting it and letting the patients know about it.
That pathology also includes pathological records that you see in the adjacent teeth. Many times we forget that the adjacent tooth may be a contributing factor for an infection. Even, for instance, if we have a root canal that is leaking and what have you, as is shown right here, restorative and structural integrity of the existing teeth and prosthetics. So adjacent teeth have a very important part in our diagnosis to see if we need to treat that underlying pathology first before proceeding to our implant placement.
Now, we might have a periodontal issue on the upper right quadrant and not have any type of issues on the other side. However, we need to get that periodontal disease under control, because those bacteria are not going to stay static in those pockets. They're going to be everywhere in the mouth of the patient, and we want to make sure that whatever type of therapy that we do, it is as successful as possible. We're also going to look for vestibular and palatal depths when we're making our decisions of the type of therapy that we're going to be doing. Of course, the periodontal status, as we've been mentioning it already several times, we recommend that every patient that you see in your practice gets a full periodontal charting, an analysis of occlusion, jaw relationship, interarch space, and the maximum opening. Especially when you're working with these long drills in implant dentistry, you need to make sure that those drills fit in the patient's mouth, especially when you're going all the way back to the first or second molars, where the opening is limited, and many times you have difficulties in placing your instruments. And of course, we want to know if the patient has any parafunctional habits and any oral hygiene habits that need to be modified prior and after the implant therapy. Now remember, implant survival can be affected by these and many other situations, but we know that smoking or smokers, uncontrolled diabetics, patients with active periodontal disease, and even more, the combination of those three categories will be a very, very high risk for those implants to fail.
So, as part of the diagnostic environment, we have a comparison of whether or not we're going to go into traditional workflows or digital workflows. Both are valid. One doesn't override the other. One actually could complement the other. So if you start with a traditional cast and traditional wax up, you will be able to have the lab fabricate a diagnostic wax up that will indicate the position of your implants. If you do digitally, you capture the image and you could do this wax up specifically in the computer program. What this is going to help you on is going to be in the particular position of the implant, but you cannot always capture in the diagnostic wax up what the patient will look like. So we encourage you to have something in your armamentarium, which is the extraoral photography and the intraoral photography, which means you will be able to capture different parameters: the lip support, the smile line. But the smile line is not always true when the patient is forced to smile. Therefore, if you are able to capture in your photography an spontaneous smile, will be even better for some type of prosthetic designs that you would like to do.
You will see in the course we're going to teach you to look at all the angles while you're placing an implant. And I would recommend to do the same thing when you're looking at the patient extraorally. And when you're taking your extraoral pictures as well, make sure that you force that smile to go as high as possible from all the angles, and you can visually see and show the patient how they smile from one side compared to the other. And that's also going to help you with the patient expectations and tell them what can they expect from the treatment and understand what their problem is in reality. Along the extraoral photographs, the intraoral photographs are also going to be very important. And we can take some limited pictures like the ones in the middle, which are going to be just a full display of all the teeth and the occlusals, but we can also go into more specific photographs like the full arch photographs or the photographs by sextants on the buccal and the lingual, which can show you more specifically how the situation is in one area.
Why is this important? Because implants are planned with a prosthetic outcome in mind. We do not put the implant where the bone is. We put the implant where prosthetically needs to go. And if we don't have enough bone, then we'll create it and we'll do adjacent procedures that will help out to place the implant where it needs to go.
Our next step is the diagnostic imaging. And diagnostic imaging can be divided into 2-dimensional and 3-dimensional. And remember, for example, on that picture of that periapical image, you can start to see that there's a septa happening on the sinus. However, without a 3-dimensional image, you're never going to know how high that septa goes. Does it divide the sinus into different chambers? And that's going to be very important on how you're going to be approaching your case surgically. So if you have the capability of getting a 3-dimensional image, you're going to be able to learn and understand more the specific anatomy of your patient, which leads us to the next category, which is anatomy.
Now, don't forget that you should be able to get this imaging for each of the patients that you will be treating on site in our course. As well, we will teach you how to look at these images and how to dissect and look at these anatomical landmarks. So knowing your anatomy is crucial for implant placement. The first part of the anatomy that plays an important role for what we do is the maxillary sinus. Maxillary sinus can be manipulated in different ways, but the residual bone that we have between the crest of the bone and the base of the maxillary sinus is very important because that will determine whether or not we are able to straightforward to place an implant in such areas or if we need to do a sinus elevation. And a sinus elevation is obviously building bone inside of the bottom part of the sinus to be able to accommodate an implant.
Also keep in mind all the vascularity and innervation in the area. Remember your the trigeminal nerve and the 3 branches, how they are separated, because when you're working in that area, you want to really be careful of either exposing the nerves so you don't damage them, for example on the mental nerve, or staying away from those nerves when you're starting to place implants and you're getting closer to that area. And we're going to show you as we go on with some images from CBCTs how you can identify the nerves and also surgically how you can avoid damaging those vital structures.
As an example of that, we start looking at the mandible. And the mandible, we have certain reservations. The very first one is the mental foramen. And the mental foramen, as we know, is located in the area in between the premolar, typically. And it's located somewhere at about 25 millimeters from the crest of the bone in a healthy patient. However, in patients that have residual bone loss, this could be very close. Additionally, we have the mandibular foramen. And in the submandibular fossa, we have the nerve supply and the blood supply that runs around that area. So we want to make sure when we do a flap elevation, a full thickness flap elevation that we'll describe later, we'll be able to trap the nerve and artery and will be protected from our doings.
So I know that all of us, we always look at panoramic x-rays, but it's also very important that you start to identify where all those structures are, because when you're starting to place implants, you really need to measure and find where they are, how they turn, if there's a curvature on the mental foramen or an extension on that mental foramen. And in reality, the only way of knowing that is if you use a cone beam to understand and dissect on slides where those structures are exactly on the area that you're going to be working on. So let's talk about some of the most important anatomical considerations. If you're working on the anterior maxilla, on the central incisor area, look for the nasopalatine canal. That incisive canal can be avoided or should be avoided unless you need to work into that area where it's totally acceptable to remove that nerve and that content of that canal, and now place your implant into that area. Now, if you're going to be removing the content of that canal, make yourself committed to removing all the content of it and really cleaning it from all the soft tissue that might be in it, and then grafting on it. Second anatomical consideration is if you're not going to be working in the sinus, try to maintain your implants about 1 millimeter away from the floor of the sinus. Many times we have to go into the sinus, and if you're going to be doing that, make sure that you're willing to manipulate or know how to manipulate that maxillary sinus in case that it's needed. Third anatomical consideration, stay 1.5 millimeter away from the roots of adjacent teeth. However, measuring 1.5 millimeter is very complicated, and especially for those novice and intermediate students, keeping 1.5 millimeter is going to be even more complicated. That's why we recommend to stay at an average of 2 millimeters from adjacent teeth rather than the typical 1.5 millimeters from the roots. Our next anatomical consideration is your inferior alveolar nerve. Always, always, always stay at least 2 millimeters superior to that mandibular canal. Why? If we damage that canal, we're going to damage the sensitivity not only of the teeth, but also of the lip on that side.
It's important to acknowledge that when we place our implants and the way we are trained, when we do restorative treatment, is to do a nerve block, an inferior alveolar canal block. The problem with this block is that if we are doing our osteotomy to place our implant and if we are in close proximity to the nerve, we do not have a feedback mechanism. Whereas if instead of doing a block, we do an infiltration, this is going to help us to be able to have a feedback mechanism. If you are getting close in the drilling sequences, close to the nerve, the patient is going to tell you that it's starting to feel that area.
Once again, cone beam is going to be very, very valuable in this type of situations. You're going to be able to locate the position of that inferior alveolar nerve, so you're always away from that area at least 2 millimeters. Next anatomical consideration is when we're working next to an existing implant or we're going to be placing two implants together. You want to have at least 3 millimeters of distance in between those implants. So this starts to go into your mind, well, if I have a space, how many implants can I place and what size of implants can I start placing if I need to have a distance of 2 millimeters in between implant and an adjacent tooth and at least 3 millimeters between the implants. And we want to maintain those 3 millimeters in between the implants because we want that residual piece of bone in between there that's going to replicate the papilla in between those implants. Why? Because we know that the biologic width around those implants is going to be of approximately 1.3 millimeters around that implant. So we have 0.2 millimeters of safe distance from one side and 0.2 millimeters of safe distance between the other side so those biologic widths don't overlap, and we don't keep on destroying more and more bone in between those implants. Next anatomical consideration is the anterior loop of the mental foramen. For that, a lot of people have created a formula stating that most of the times that anterior loop moves 3 millimeters mesial from the mental foramen, and from there you should measure 2 more millimeters anterior to that to be at least 2 millimeters away from the mental foramen, or the loop from that mental nerve. However, we encourage you to get rid of that rule and locate the loop with a CBCT and know exactly how far away are you going to be from that loop on that mental foramen area. And another consideration is on your posterior mandible, there's most of the time a mandibular undercut that is found below the malohyoid ridge. Once again, you can find that with a CBCT and decide if you put a very long implant in that area, you're going to be breaking through the lingual cortical and falling into the soft tissue, nerves and arteries that are found into that area, and you really want to avoid perforating that cortical and keeping your implants totally into the bone. So once again, CBCT, which we have on site, is going to be very, very valuable to identify all those important anatomical structures.
Now we're going to go and discuss the prosthetic considerations. As I said before, it's very important to understand that all implant surgery should be executed with a prosthetic mindset, which means for us that we have to understand that more than 35 million Americans do not have any teeth, and 178 million people in the United States are missing at least one tooth. These numbers are expected to grow in the next 2 decades, so we have a prime market, a prime niche to continue to be successful in the implant dentistry.
In 2002, the projection was that we were going to go from 33 million patients to 38 million patients in 2020. Well, let me tell you something. We're already in 2020. So this projection is true, and this projection is getting bigger as we speak.
So let's look at the definition of success. There's a certain criteria for success, and that criteria is divided in health, comfort, and function.
And that criteria of success for teeth shouldn't be different for implants. Implants should be healthy. The patient should be comfortable. Those implants should be functional. And for that, in 1986, Albertson came with his criteria of success: the absence of mobility, the absence of radiographic peri-implant radiolucencies, vertical bone loss that would be less than 0.2 millimeters on after every year, the absence of persistent or irreversible signs and symptoms, and within that context, the success rate of implants were 85% after 5 years and 80% after 10 years. Now let me go back to 1986. The implant technology that we had back then is totally different to the implant technology that we have nowadays. Nowadays, if you read the literature, you're going to see that most implants or most articles quote that there's a 95 to 100% success rate within 5 to 10 years. Let me tell you something more. Nothing is 100%. So I would say that implants are successful about 95% in a period of 5 to 10 years. Now let's look at this case radiographically, and let's analyze the criteria for success. Those implants don't move. There's no radiolucencies, no vertical bone loss, no irreversible signs and or symptoms, and those implants have been in the mouth of that patient for more than 5 years. Now let's look at the clinical image, and I want you to think to yourself, is that a successful treatment or not? Well, we ask the patient to smile And I'm going to ask you to think about it one more time. Is that successful when we see the display of the lip of that patient? And if we were to look in 1986, yes, that was a very successful case. It has been in the patient's mouth for more than 5 years, very successful without any symptoms. However, in today's world, this is no longer acceptable.
So we understand that patients' expectations have increased from what the profession could offer in 1986 to what the profession offers today. Both the appearance of aesthetics, implant restorations, patient satisfactions, and clinicians' ability to perform tests is very important. So therefore, in 2000, the American Academy of Implantology came with a position paper showing that the patient and clinician satisfaction with the aesthetic appearance of the implant restorations. So it's no longer only the clinical, also the aesthetic appearance and patient satisfaction, as well as clinical satisfaction.
So if we go back to this slide where we see GV Black on the left, and we think about the criteria of success for both teeth and implants, yes, health, comfort, function, but in today's world, we have to add aesthetics. And how are we going to be able to give a healthy, comfortable, functional, and aesthetic restoration? By improving the skills of our operators. And that's why you're taking this course, because you want to improve your skills to give better results to your patients. So if we look on this graph, we can see in blue on the right side of the curve, back in the day, a very small amount of dentists were the only ones doing implant dentistry. And they were very specialized in what they're doing, and they were very, very successful. However, nowadays, that curve is a little bit different. There's dentists all over the spectrum placing implants. And as I mentioned, that's why you're taking this course, because you don't want to be doing those things. You want to be on the right side of the spectrum. You want to be on the high quality of the spectrum. That's why we're having maxillofacial surgeons and periodontists teaching you all the skills to be able to perform adequately your implant surgical procedures with a prosthetic mindset.
So we have to look into 3 different prosthetic solutions. One is a dental prosthesis, the other one is dental-alveolar prosthesis, and the last one is going to be a removable prosthesis. All of them with an implant component, of course.
And it doesn't matter which type of prosthesis you are going to deliver to the patient. All those prostheses need to be done with a prosthetic mindset. On the anterior or on the posterior, if possible, try to place those implants to be screw retained. However, it's not always going to be possible. If you need to be dealing with cements, make sure that you really remove those cements adequately, because all that bone that you see on those x-rays that was formed to be able to maintain the soft tissues around those implants to give it a natural emergence profile and natural view can be destroyed if you leave some cement behind. A problem that you don't have if those implants are planned to be screw retained, like in this case. Also in the posterior, try to avoid your cements. If you can place screw retained, try to do it. If the case doesn't allow because the bone doesn't allow it, doing cement retained is totally acceptable as long as you do it properly.
You also have to know your implant system, for which in this case we have partnered with MIS, the C1 implant, which is the most versatile implant of their line. We have to understand that this implant is composed of specific raw materials. We have a titanium 6A grade 23, and this alloy combines a biocompatibility, an excellent fatigue strength, and low elastic modulus.
This material is going to be much stronger than the typical grade 4 titanium found on most of the other implants available in the market.
But the surface treatment is important to understand it because, as I mentioned at the beginning of this lecture, that the contact osteogenesis will happen if there is an affinity between the progenitor cells and the surface. So therefore, in this particular implant that we elected to use, we have a sandblasted and acid-etched surface, which is roughening the surface to the level of certain porosity, as you see in the screen, and increase the implant surface area by creating these both micro and nano structures. So the more porosity, the more surface area that we will have in order to have this osteogenesis, contact osteogenesis to happen. And it eliminates the various surface contaminants. Also, we understand that this implant is a conical shape design which ensures a superior primary stability. The primary stability actually is ensured in this or any implant system by the thread design that we will discuss in the next slide. The ultimate choice for a wide range of clinical cases and loaded protocols is typically done using a conical shape implants. It's also ideal for narrower spaces and restricted by adjacent teeth or implants, as we know this conical shape tapers as the root of the teeth. Now, the dual thread design of this implant increases the bone to implant contact over the entire body of the implant. And the insertion rate, it facilitates a simpler and faster implant placement. Now, this is important to understand. There are two concepts in here. One is the primary stability, and the other one is the osteogenesis around the implant. Primary stability is only and exclusively related to the thread design of the implant, and the implant has a sufficient bone to implant contact and a good thread design, then you will be able to obtain primary stability. But from that point on, the thread design of an implant doesn't have much to do anymore. The next element will be the surface preparation of the implant, which will help to the initial phases and late phases of osteogenesis. In this case, we have two spiral channels and a domex apex, which this provides a high tolerance and safe procedure during insertion. So having a dome shape at the apical extent of the implant will prevent damaging some anatomical structures if we were to be too close. However, the two cutting blades at the implant apex establish the self-tapping properties. Self-tapping means that the implant will engage and break the bone and anchor itself into the bone because it's a cutting thread design. Therefore, these properties will make the implant simpler, safer, and faster procedures. Now, we also have at the level of the neck of the implant of the C1, we have micro rings. These micro rings significantly increase the bone to implant contact, and these are supposed to help to avoid the bone resorption in the crestal bone. Even though we understand there's going to be a little bit of bone remodeling in our implants, these micro channels at the level of the crest will help with this bone to be supported for more to bone to implant contacts. Now, let's look at the conical connection. A conical connection is important to understand in our implants because the conical connection will offer a precise fitting of your abutment. And the 6-degree of conical connection between the abutment and the implant will ensure this preventing this micro movement or micro motion. Now, in years past, you probably are familiar with the concept of micro movement and micro motion. That micro movement led to a lot of loosening of the prosthesis, and a screw comes up, the screw gets broken. The problem with this is that the internal connection was a failure because it was not internal connection at the time, it was an external connection. So therefore, many years now into our new technologies, we understand that the Morse taper or taper connection will help to ensure that there is no mobility or micromotion at the level of the abutment. So it minimizes the micro movements by reducing the bone loss at the crestal level. Not only that, this implant offers 6 positions cone index within the conical connection to help orient the implant during the insertion, as well as placing the abutment into the proper position. Now, let's look at this concept, because this is a very important concept as well. The concept of platform switching or platform shifting. It's a semantics, of course, one gets confused one to the other, in myself. However, this platform switch design keeps the implant abutment connection away from the bone. Put it this way: if the purpose of the tissue and the biologic width is to protect the bone, by making the abutment smaller than the actual platform of the implant, that means that the tissue will invaginate, as indicated in the blue lines on the picture on the left. This tissue will invaginate into the abutment and will offer a better protection of the bone remodeling, because you will not need to have that much bone remodeling because the tissue is protecting that bone. So it minimizes the bone resorption and it allows more vital growth of the soft tissue, which leads to the next concept, which is the concave emergence profile that MIS C1 components offer. This concave emergence profile actually allows the soft tissue to invaginate into that concavity and even offer more protection to the biologic width. It's also a golden shade to support the high aesthetic results, and it's color coded for a simple and immediate platform identification. The positioning groove ensures definitive fit over the implant. So what is important of this prosthetic design is that all components have the same platform shifting support, which means the concavity that you see in the prosthetic abutment, from the healing abutment, from the impression cupping, from the temporary, cemented restoration, or screw retain or CAD/CAM restorations, you will have the same profile. This is contrary to what we know or we have been taught in the school years past, where we have to make that extra convexity of our emergence profile. Instead, the convexity, we would like to keep that concavity, and this, unfortunately, is not a concept that is very well understood, but years of research has shown that this concavity will have aid into the platform switching support. Now, let's look at what's in the box that has an MIS C1 implant. We have the implant itself, and we have a final drill. The final drill is very important because most of the literature that refers to burning of the bone or thermal necrosis or even compression necrosis relies onto the using of dull drills. Many of us, unfortunately, would not mark down how many times we have used a drill. However, when they have packaged a final drilling sequence along with the implant, that means that this drilling sequence is always sharp and is always new, and obviously is disposable because each box comes with one. In addition to that, we have a temporary cylinder, and this temporary cylinder is very convenient, especially if you want to do an immediate loading or immediate temporization, practically talking more about the anterior segment. And you don't have to invest more into the purchase of this additional component. It comes with it, along with a cover screw.
Now let's move on to our next category, which is surgical considerations. And it's important to understand common implant surgical errors and to learn how to avoid them. And we're going to continue with this concept of knowing our implant system, because that's going to really help us avoid a lot of the complications if we know what size of implants we have in terms of width and length to maintain that distance in between teeth and implants, to maintain that distance from the crest of the bone to the nerves or the concavities on the bone. So on the C1 implant, you're going to have 3 different platforms: narrow, standard, and wide. The narrow platform, it's going to be a 3.3 width in the coronal aspect, and it's going to taper to 2.75 on the apex. You have it on the different lengths of 8, 10, 11.5, 13, and 16. Then for the 3.75 and the 4.2 millimeter implants on the coronal aspect, they're going to share the same platform, and everything is color coded to make it easy. Why? Because those 2 implants are going to use the same prosthetic components, whether it's a 3.75 or a 4.2 millimeter implant. And then the green, the white platform, that comes on a 5 millimeter on the coronal aspect, and it tapers down to 4 millimeters, 4.5 millimeters on the apical portion. Same length for those implants as well. And your drilling sequence is going to be very simple. If you're placing a 3.3 millimeter or narrow platform, you're going to do your spear drill initially to mark where you're going to put your implant and help you stabilize that initial drill. Then you're going to have a drill that has a stopper that you're going to drill down to your final length. However, if you're not sure of the distance to a nerve, always drill short. You can put a pin, and if you need to drill deeper, you can do it after you have confirmed that you're far away from that vital structure. And very simple, if everything is in the correct distance and position, if you have a type 1 or type 2 bone, you will decide to use your final drill. However, if you're drilling on a softer type of bone, type 3 or type 4 bone, you may decide that you don't want to go to your final drill and just position and place your implant after using only that first drill into the bone. Same protocol for the 3.75, which has a standard platform. However, we're going to use the red drill. That one does not have a stopper, and it's important to know that because it has some markings, and you're going to be looking at the chart and measuring how deep you're going to go, and you're going to stop where those markings are at the crest of the bone. Same thing, if you're on a type 1 or type 2 bone, you may want to jump to your next drill, which is your final drill, and it's a fresh, brand new drill that comes with every implant. However, if you're in a type 3 or type 4 bone, you're not going to be using that drill at all, and just go and position your implant. Something to keep in mind is because those implants are self-tapping, you've got to continue the same path of insertion of your initial drills. Otherwise, you can change the position of that implant, particularly on type 3 or type 4 bone. The 4.2 implant, which is the same platform as the 3.75, is a standard platform. You're going to use one more drill, the blue drill. Remember that for the red and the blue drill, you're also going to have some indicating pins to check your angulation and also to take some x-rays in case you want to do it. Final drill or no final drill, depending on the bone type. And you're going to use your last drill if you want to expand for a 5 millimeter implant in width. And same thing, you will decide whether you want to use or you don't want to use your final drill, depending on the bone quality that you have. And then here comes the question, should I put a cover screw or should I put a healing abutment? Do I do a 1-stage or a 2-stage implant procedure? And what we're going to recommend is that if you have bone surrounding that implant and you don't need to do any additional bone grafting procedures, it is safe to do a 1-stage implant procedure where you put the healing abutment that day. However, we recommend that if you're doing additional bone grafting procedures or other type of procedures, you try to submerge that implant with a cover screw in place.
In this regard, there is an important consideration. The healing abutment, if you choose to do a 1-stage procedure, the abutment has to surpass the gingival margin, and this will allow the gingiva to hug and heal around that healing abutment. If this abutment is not tall enough, then the gingiva is going to grow on top of that abutment and will defeat the purpose. There is a new system that will not be shown today, but is also a good system to consider for the MIS line of products, which is the Connect. And the Connect is an abutment that sits on top of the implant that will serve the purpose of a healing abutment, but also will serve the purpose of the final abutment. So if you have more questions, just let us know. We'll be happy to share information about that system.
Here is a quick video of with the stoppers, and then depending on what type of implant you're going to be using in terms of size and length is the type of depth that you're going to be drilling and the type of drill that you're going to be moving forward with. And we're also going to give you charts so you can have them on your hand next to you on every surgery to know the lengths and the drilling protocols that you're going to be using. One more time, remember that each implant is going to come with a final drill, and there's a reason for that, and you may or may not use it depending on the bone quality that we're going to have.
What you see here is exactly that. We will not spend too much time reviewing this chart, but you will have that available in a laminated protocol to take with you, because actually these are the settings that you'll be looking to in order to do your procedures, especially when it comes to the drilling sequences, or if you need to do alveoloplasty, or if you need to do some corrections.
We talked about understanding the alveolar ridge in terms of size, in terms of bone quality, but we didn't understand what happens with the ridge. Why does that happen and how does it happen? And everything starts with an extraction. Everything starts with the etiology of the natural remodeling of the socket after a tooth comes out. And we know that when we take out a tooth, there's going to be a remodeling process that's going to be most accelerated in terms of resorption during the first 2 to 4 months following the extraction. And we also know that that process is not going to be complete until 6 months to a year after that extraction happens. We know that we're going to lose 50% of horizontal bone over a 12-month period. And we know that 2/3 of that bone loss will occur during the first 3 months. The other thing that we know is that sometimes what we see clinically is not what we have on the patient's mouth. So once again, having a CBCT is going to be really, really helpful to understand how the anatomy is underneath those gums after a tooth has been extracted. We're also going to have some vertical changes. Between 1.7 millimeters to 1 millimeter of vertical bone resorption can be seen during the first year after the tooth is extracted. And why does this happen? Well, it happens because of a loss of vascularity in many different aspects. A loss of vascularity of the periodontal ligament that feeds the bundle bone, which is the bone that has those fibers inserted from the periodontal ligament. A loss of vascularity from the cortical bone, because we don't have a lot of bone marrow in that very thin bone. It's only cortical bone on the sides. And a loss of vascularity from the periosteum in case we elevate a flap. Therefore, we've got to understand the alveolar bone. We've got to understand that the supporting bone, which is what's going to be holding the bone that holds the teeth in place, has a cortical and cancellous bone. And the alveolar bone proper, which is the bone that's surrounding those teeth, or well known as the bundle bone, is going to be a very, very thin piece of bone and a very thin layer of bone where the Sharpie's fibers are going to be inserted, and that usually measures between 0.2 to 2 millimeters. Now, if you think about that, not a lot of teeth, especially in the maxillary anterior part of the mouth, are going to have more than 2 millimeters of thickness. Therefore, most of that bone on the facial of maxillary anterior teeth is going to be bundle bone in its entirety. And all the vascularity of that bundle bone comes from those periodontal ligaments, not from the supporting bone. And many times there's very little bone marrow in between those cortical plates, and all that bone dies, unless we have a thicker plate like on this histological slide, where we have some supporting bone and not just bundle bone. And that usually happens on the posterior mandible, sometimes in the posterior maxilla, except on the first molars. However, that can really, if we don't have that, we can really have a lot of bone resorption. The supporting bone, all that vascularity is going to be given by the cancellous bone and the periosteum, as we mentioned before. And once again, the bundle bone is going to be fed by the periodontal ligament. And if we don't have that periodontal ligament anymore, we're going to be losing all that vascularity.
How can we counteract this? What we're thinking of is if we have that very thin alveolar bone that remains after extraction, we would like to graft because we have lost the bundle bone, so the rest of it is cortical. Failure to do that is going to translate into a bone resorption. However, if we place a bone grafting procedure, or an allograft in this case, we will be able to preserve that buccal plate without resorbing.
Now, genetics also plays a big important role in this situation, and you can start analyzing both of these cases. You can see a patient with a thick, flat biotype where the tissues are thicker, the teeth are more rectangular or squared, or a thin biotype where the tissues are more thin and the teeth are more triangular. Obviously, if we start looking anatomically at those patients, we can see that if we were to lift the flap on a patient that has a thick, flat biotype, the bone is thicker. We don't see a lot of dehiscences or fenestration in there. However, on a thin scallop biotype, if we were to lift the flap, we would start to see some fenestrations or dehiscences on the bone. Once again, if we look this underneath a CBCT on the thick, flat biotype, we would see a thick cortical of bone. And if we see a thin scallop biotype, we would see either a very thin piece of bone, or we wouldn't see any bone at all. On a diagram, we can see, once again, the supporting bone versus the bundle bone. And if we don't have any of that supporting bone, all that bundle bone is going to be lost in those cases where we have 100% bundle bone and no supporting bone at all. We've also got to be careful once we're doing extractions. We're going to teach you how to section teeth. We're going to teach you how to take teeth with periotomes. We're going to make it easier by using the piezotome to be able to take those teeth out. So when you're taking those out, we can maintain as much bone in that area as possible. So prevention is going to be very important. We're also going to look at immediate implants. Do they play a role in preventing bone resorption or doing ridge preservation? When do we do one or when do we do the other? We've always learned that when you take something out, we should put something back in that place. And we've got to learn what should we put back and when should we put it back.
Well, let's understand, as I mentioned before, what is important is to be able to protect that thin cortical plate where the bundle bone is not present, because all the blood supply has been negated. In this slide, we show that Araujo presented a histology in a ridge preservation study on the left side compared to the simple extraction on the right. What we noticed that the very similar cuts in the same area, we illustrate on the left that by doing a ridge preservation in a bone grafting procedure in a socket and alveolus after extraction gets to preserve the width of the bone when compared to a simple extraction site on the right. So therefore, the first step is to consider the use of periotomes. Periotomes are very thin knives that the purpose is to be inserted into the interface between the PDL and the tooth at the level of the crestal aspect in order to remove or cut these crestal fibers. What that means is that by using this periotome, it's going to help us to achieve that extraction in a less traumatic way. Alternatively to this, we have another innovation in our technology, in our industry, which is the Cube piezotome made by Action. They are very sophisticated machines where the different tips in a very versatile, but in this particular case, we have a particular tip system that's called extraction. And the extraction tip system will help us to replicate the action of the manual periotome, which means is that we'll be able to cut those fibers in a more precise way, allowing us to remove the tooth very non-traumatically.
The next thing that we need to decide is if we're going to be grafting that side, what type of material we're going to be using. And there's a lot of materials out there in the market. If we were to categorize the materials, we are in our mindset, our first choice is going to be a freeze-dried bone allograft. However, it's not everybody's choice, and there's other materials available. Demineralized freeze-dried bone allograft, autografts, or xenografts would be our second choice, and alloplastic materials would be our third choice in those cases where patients do not want any materials from other humans or other species.
You have to understand what the bone graft is going to do for you. The bone graft doesn't have live cells, so therefore it's going to act as a scaffolding for the own cells of the host to grow through that scaffold and eventually replacing this bone. Freeze-dried bone allograft, which is the FDBA, is a bone that doesn't turn over very quickly. That means it will stay on site for a minimum of 3 to 4 months to allow this conversion of a matrix of osteogenesis and bone formation to happen, and eventually it's going to go away. Demineralized freeze-dried bone allograft, the second choice, DFBA, is a material also come from a human donor, but in this case, this bone is demineralized, which in essence, this bone is going to turn over rate very fast as sometimes in 3 months we no longer see the particles, which means that it may not last as long as we want for the complete maturation of the matrix between cancellous bone and the osteoid. Obviously, the autograft, the bone from the patient's mouth or other part of the body, is certainly a treatment of choice. However, the limitations are that we have to do a second cycle of surgery to be able to harvest that, and the availability may not be as good, and the turnover rate is high. Xenograft, however, which is bone from a animal source, this has been demonstrated that it lasts for a long time. Actually, studies have shown histology that this bone does not resorb. So ultimately, if we want a material that eventually converts to the patient's own native bone, and we use a xenograft or furthermore an alloplast, which is typically a lab-made material out of organic components such as hydroxyapatite. In this case, the xenograft or the alloplast typically will not resorb, and you will have the last choice. What would you like to have an implant contact? A material that has not been able to turn over to a native bone, or a material that has completed turnover rate and has converted into the patient's native bone.
The next thing that you need to choose is what type of membrane you're going to be using. You want something that's biocompatible, something that has low risk of infection or if it is exposed, something that has a slow resorption rate when it gets exposed, something that's easy to handle, and the cost. And we're going to be using different materials.
Growth factors are important because growth factors have an ability to stimulate the formation of that matrix of bone. Actually, most of the growth factors have a chemotactic activity where the cells are called to proliferate into the area that are placed into. For that, we have different growth factors. We have bone morphogenic proteins, BMPs. We have PRP, which is an isolate of the protein-rich plasma, platelet-rich plasma, which comes from the blood and is spinning the blood and making that plasma more available for the bone to grow. We have recombinant PDGF, PRGF, MDOGAIN, and IGF. From here, the ones that we will have available to you to use is the ones that you have to evaluate as the most cost benefit, which in this case, perhaps the most cost benefit for all of us is going to be utilizing the patient's own blood to be able to isolate the growth factors from this blood and put them back into the site that we're trying to grow.
Now that you have all this knowledge in your heads of what materials we have available, what are our preferences, you can then start to make a decision of what you're going to be doing when you have a patient in all different situations. And for that, we've created a classification of sockets where a type 1 socket is a socket that has a thick cortical, has some supporting bone on the facial, and you know that because of that supporting bone, there's going to be some cortical bone giving some innervation into that area, and as a result, there's going to be a thick cortical bone that won't resorb no matter what you put into that socket. A type 2 bone is going to be that has a very thin buccal plate, usually, and it measures less than 2 millimeters, and most of that bone is going to be bundle bone. A type 3 socket is that one that's going to have either a thick or thin cortical on the outside, but it's going to have a fenestration, and the type 4 is the one that's going to have a dehiscence, meaning that you've lost most of that buccal bone, either because of the genetics of the patient or because of the trauma that was performed during the extraction or because of the disease that created the loss of that tooth in the first place. So based on that is your treatment choice. If you have a type 1 bone, it doesn't matter what you put in there, thick buccal and lingual corticals. You can put a collagen plug and something will regenerate in there without any problem. Type 2 bone, you're probably going to lose that buccal plate. We need to put some bone that's going to last there during the whole healing process, and we're going to put some sort of membrane so nothing goes in there. Type 3 bone, you may want to lift the flap and cover that buccal bone with some of that membrane to isolate the soft tissue from that fenestration area, and obviously a type 4 bone where you don't have that buccal plate. And I'm going to show you here a case of a type 4 defect where there's no buccal plate presence, even though you still have the septum. And if you do a ridge preservation procedure, then you can come back very easily to place an implant back in that area. What do you prefer? To come back to see a nice ridge of bone, or do you prefer to come back and see a very thin ridge of bone that's going to require more expensive, more difficult procedures to be able to regenerate that bone and to be able to place implants in there? And even if you were not thinking about implants, even if you were thinking of a 3-unit bridge or a 4-unit bridge or a removable denture, what do you prefer to have, a thick ridge of bone or a thin ridge of bone after you have extracted those teeth? I think everybody would prefer to have a thick ridge of bone. Now, if you're thinking about immediate implants, obviously the type 1 ridge or socket is going to be the ideal socket for immediate implant. Why? Because even if you were to lose a little bit of that buccal plate after the resorption of that process, you're still going to have some of that bone remaining on the facial, which is going to be crucial for your survival and success of that implant.